thanks for coming with this weather, for those of you who braved the cold and the rain. This is the second of our speakers for the 20th Lefeber series on aging. And I want to start immediately with introducing our speaker today, who's Dr. Carmen Garcia Peña from Mexico City. Dr. Peña is the head of the Health Policy Research Department in the Research Division of the National Hospital of Pediatrics, the Ministry of Health, and is a member of the National Academy of Medicine in Mexico. She worked for many years as head of the Division of Evaluation and Use of Research Results in the Mexican Institute of Social Security, and she just moved to this new position very recently. Because although her interest is on aging, she actually is now charged to come up with a way to research how we develop in Mexico, particularly how individuals develop throughout their life up to an older age. And so she's charged to look at all the lifespan, really, of individuals in Mexico. She's published many peer-reviewed papers. She had 72. She's edited or co-edited 11 books and 36 book chapters. She has more than 480 citations. And today she's talking. I would like for you to join me in welcoming Dr. Garcia Peña, and who will speak about the health system in Mexico and the challenges of aging, frailty, and emergency services.
Thank you very much. Good afternoon. Thank you for this very nice presentation, and thank you for the invitation. My special thanks to Rebecca for the invitation. And I also want to thank Stephanie, who has been very helpful with all these logistics and the travel arrangements. She has been very nice. I have been working on aging topics since many years ago, since my doctoral studies. In the last few years, in the last 2 or 3 years, doubts and a sort of questions about the relevance of my research and the real impact of my research in real older adults is starting to worry me. I know that this is a sort of philosophical question about the final meaning of what I'm doing, but to be honest, I may share with you more questions and answers, but I really hope that the discussion would be more interesting if there is time at the end of this talk. So I try to organize the presentation thinking about several levels, because I really think that some of this data can help to understand the complex reality of Mexico facing the aging process. And with this in mind, I will present a little data about the macroeconomic situation, how the health system works, some obvious and very well-known data about demographics and epidemiological transition, and I will try to link this information with frailty, a topic very much discussed nowadays. And finally, I will try to make some conclusions. Some general data comparing the US and Mexico. And it's clear the difference between several variables. But the most important point is the level of marginality and the uneven distribution of wealth in Mexico. The proportion of all people, the level of poverty in Mexico, it's around 45%. And this figure has not decreased in a very significant way, maybe in the last 20 years. This map represents the level of marginality scored by Coneval. Coneval is, I think, is a very reliable institution that is focused on the evaluation of government programs. And they developed an index composed by several variables: education, income, access to health services, clean water, access, housing, and so on. And it is very clear in the map that the states in the south of the country have the high level of marginality. And the proportion of population that falls into these two levels of marginality, very high and high level of marginality, it equals more than 50% of the total population. Consequently, I always say that Mexico, it's several Mexicos, and the polarity between sectors and between groups of population is increasing. Consequently, this has important implications for vulnerable groups, including indigenous communities, older persons, children, women. And the health system is a consequence of the economic reality, at least in part. And this scheme presents the complex structure of the health system in Mexico. It is very obvious that the system is completely fragmented, even with the reforms of 2003 and 2004. Every square is a different institution. And the Mexican population then receive very different levels of care. Sources, level and funding, structure, human resources, and health impacts are not equal between institutions, and problems persist with inequity, ineffectiveness, and poor governance. And the main reason for recent reforms was supposedly to decrease the percentage of catastrophic expenditures. But problem persists. From the total health expenditure, only 50% corresponds to public expenditure, and the average figure for OECD countries is 72%. Almost half of the total expenditure is private. And also, spending in health as a percentage of GDP is 6%, and the average OECD is around 90%. Of course, one can say that spending in health does not mean anything, because countries with the highest levels of health spending do not have necessarily highest level of care. But some data from a study from PAHO reveals that a country needs an expenditure of around 7 to 8% to think about the possibility of having an universal system. And another important situation is the level of out-of-pocket spending, which it stays around 45% from the total expenditure in health. Average OECD is around 19%. And I think this issue is really important when we talk about older persons. A survey reveals, a Mexican survey reveals, that one of the more relevant concerns of older persons is the expenditure in medicines and the possibility of needing an hospitalization, because when they need more, they have less. And of course, the catastrophic consequences in family economy are really big. Again, regarding marginality and health resources, an analysis crossing several public databases reveals a complete inverse situation in terms of poor and rich counties. This graph presents columns. These columns represent the percentage of counties that have very low, medium, high, and very high level of marginality. And we can see that counties with very low level of marginality have less people without social security, less people without clean water access, and more doctors compared to counties that have high and very high level of marginality. So to close this section, just one final point. It is really difficult to say how Mexico will be able to face the future and the health needs of all the persons. Public spending on long-term care does not exist. Mexico does not report this data to the OECD system, and healthcare institutions, public healthcare institutions, limit the provision of health services to acute care, hospitalization, and other things related with ambulatory care. But public programs of home visits, daycare centers, long-term care institutions, nursing homes, do not exist. So as a general health system facts, I can say that there are several vertically integrated institutions, but for different parts or different sections of the population. Outside the social security system, funding is not very clear. How the money arrives to the state is not very clear. Out-of-pocket spending is the highest in OECD countries, around 45%. The annual growth rates for health expenditure over the last years is below the average of OECD countries. And maybe, I can say, maybe the most three important points. Health policy is fragmented, divided between federal and state governments, and divided between institutions. Universal coverage, I'm sorry, maybe this is controversial. For me, it's a myth. It's a Mexican myth. And inequity and high percentage of poverty persists. And in terms of epidemiological and demographic transition, I know there are experts present in this room, and I just want to put some points into the discussion. And the first one is the speed of the process. It's the speed of the process. As we can see, the doubling of older persons as a percentage of population was gradual in developed countries. And this process, however, is accelerating in a very fast way in Mexico and Latin America. And the same change will take only around 27, 28 years for these countries. This fact makes an important difference. And this table confirms the data. The increased rate of the total population between 2014 and 2050 will be around 2%. But however, the change of population 60 years and older will be more than 500%. And of course, increment in the total number of deaths will be at the expense of all the peoples. And yes, life expectancy will be increased at around 5 years to 2050. But once again, the increase in life expectancy will not the same in the country. The last 4 states that also have the highest level of marginality will have at around between 2 and 3 years less in life expectancy compared with the other states. And so it is true that Mexicans are living longer, that it's a fact, but in what conditions? This slide presents the 10 main causes of death from 1940 to 2010. And it's really interesting to see the pattern. From 1940 to maybe 1980, the beginning of 1980, infectious diseases were the main cause of death. And after 1980, the pattern changed in a very dramatic way, and heart disease, diabetes, cancer appeared as the main causes of death. The problem is that infectious and perinatal causes do not disappear. However, reflecting one reality that Mexico is living, it's more an epidemiological polarity than rather a transition. And in fact, prevalence of diabetes is rising. The figure for 2014, it's around 12%, one of the highest prevalence rates in the world. This is the last report of the International Diabetes Association. But the problem is it's not only how many diabetics Mexico has, but more importantly, what is the level of quality of care that they receive. This graph presents an analysis that grows the prevalence for, in one hand, and admissions to the hospital for uncontrolled diabetes. And Mexico appears here. And of course, Mexico has one of the highest rates in prevalence, but also has the highest rate for admissions for uncontrolled diabetes. So, of course, the main problem is lifestyles, genetics, and biological variables, but also proper care and effectiveness of the health system. At the same time, the combination, I can say, the combination of aging process and the persistence of chronic diseases have, of course, negative consequences on the aim of having an independent and productive life. We analyzed the main causes of DELIS in persons, Mexican persons older than 70, in a database called Burden of Diseases, and the change between 1990 and 2010. There are many important changes between these 2 years in these labs, but the most important change was in chronic kidney disease as a complication of diabetes, arguing that although all the persons are living longer, their health conditions are far from optimal. And, well, of course, 75%, 80% of Mexican older persons are independent. But the problem is 25, 35% has some level of disability, and they percentage use the health services intensively. So the result of this increasing life expectancy is people now either survive with more than one long-term conditions, live long enough to develop conditions of aging, become frail, develop functional, sensory, cognitive impairment, become disabled or dependent to some degree, and they are so needed on formal and informal care, and they use multiple services, and they have a lot of contacts with health staff. And this need is reflected here when consequences is higher utilization rate, but family medicine level or ambulatory visits and hospital discharge. The increase of rate for 65 years and over is more clear at about 2000. And for me, that doesn't mean that all the persons are responsible for the increase in health costs, as many policymakers always said. For me, the health system is not responding properly to shifts in growing public health demands. And on this slide, we can confirm the previous information. This analysis was made using the ENSANUT 2012. ENSANUT is the equivalent to a national health survey, and information has been collected every 6 years that are collected through self-report And the percentage of persons 60 years and over reported more frequency of hospitalization in the previous years compared to the other groups. So, in brief, in this scenario with very clear demographic challenges, an increasing burden of chronic diseases, and a very obvious financial and health system difficulties, what are or what should be the research priorities for Mexico and countries similar to Mexico? This scheme appeared in a publication in BMC Geriatrics in 2007 and integrates the main priorities in aging research. It's under discussion, but in some way, Frailty covers many of these topics, and for this reason, I decided to talk about Frailty. Because also, on the one hand, the enormous increase of research in the topic in the last few years, journals and congresses are now completely focused on the topic, and on the other hand, the importance is undeniable. However, my question is, what and how is the best way to translate this topic into research in Mexico? And questions made by Powell in 1997, I think, are still relevant. Is Frailty measurable, predictable, preventable, reversible? And it's possible to do research in the topic. And in fact, just as a curiosity, I have to admit, I looked for the now classical work of Linda Fried that you all know, and the Times cited as really impressive, more because citations had been increasing at a steady rate in the last few years. It's really a surprise to find that. But because this situation that usually doesn't happen with most of the papers. And these citations are concentrated in the US, Canada, and also in Europe. And even when there are other new alternatives, we Mexicans researchers keep moving between two paths, a Frailty phenotype and Frailty index, one understood as a biological syndrome and the other as a combination of deficits. And Mexican researchers started a few years ago, quite late, I'm afraid, to do research in both areas. And in some cases, just following the trend without deeper analysis of the topics at hand. I review the publications, and there are 8 to 9 Mexican papers published around the topic of Frailty. Many use the same database to analyze the MHAS study and for a cohort named Coyoacán study. Even though 8 of them applied the Frailty phenotype, results on prevalence are varying, and there is no consensus about cutoff points, standards, and dimensions, and it's possible that we don't know exactly what we are measuring and what that means, and or the implications these results have. This is the first 4 papers. And the last, these 4 papers use the same database, and the prevalence are different. So when we compare items among 5 of the Mexican studies that measured all the components of the Frailty phenotype, we found really important differences. More in the report of low physical activity, weakness, and slowness. Of course, maybe methodological reasons are behind self-report, cutoff points, and so on. But the point is, how frail is the Mexican population? I really don't know. And I try to make some questions about this point. For example, for me it's important how and why to screen frail elder adults in clinical practice. Is it useful for clinicians to measure frailty? How to assess frail older adults in different settings? How to look out after the causes of frailty and propose long-term interventions? How to implement clinical, interventional, and cost-effective research on frailty? And finally, for me, the most important nowadays, how to connect frailty to daily practice, what this means for services, for health services. And with these questions in mind, I decided to test the concept of frailty and their consequences in a very specific scenario: emergency services. Emergency services are especially important when we think about older persons. Crucial decisions and severe consequences are daily issues in emergency departments. In addition, the pattern of use is different compared to other age groups because of vulnerability, multimorbidity, length of stay, utilization is high, and several adverse outcomes related with the stay at the emergency department itself. The emergency department is a risk factor for loss of functionality and frailty. I have to say that this photo was taken at about 11 p.m. in an emergency department. And as you can see, there is artificial light, a lot of noise, very crowded, very noisy. And doctors wonder why the patients there get with delirium. So it's really surprising for me. Of course, Mexican hospitals are struggling every day to respond to the increasing number of older patients who need care without success. That is true. Common issues to the emergency departments are lack of opportunity, not enough beds, long stay, services are overstretched, high levels of dissatisfaction between physician and patients, buildings are not prepared, staff is not prepared, medical residents are not equipped to deal with them, and there is a high percentage of defensive medicine. And all these variables are a risk, a very important risk for discrimination. And all these aspects were the basis of a general research proposal which had the aim to evaluate an intervention based on a scheme for training emergency medical residents and geriatricians in the reduction of negative health outcomes in people over 65 years old. We have two types of outcome variables, clinical, which include frailty and health services factors. And also we had the aim to analyze the pattern of change, basically of frailty. And I will present data about this part. Regarding methods of this project, the design was complicated. It was a quasi-experimental design. It was impossible to randomize. The study was before and after with control group and parallel cohorts. And we included 2 general hospitals, and every cohort has 5 measurements. Baseline, at arrival, it was the first one, baseline, discharge at the emergency department, discharge at the hospital, and 2 months later at home. We included, we had very open criteria. We included patients older than 65 years that were admitted to the emergency department, and we excluded patients seriously ill. And this presents the general variables that we measure, and in the different moments of measurement, and here I will present data about frailty and hand grip strength. We studied 706 patients. Most of them were women. The mean age was around 77 years old. More men were married and more women were widowed the level of education was around primary school. And it's important to point out that more than 40% of the patients requested healthcare before arriving to the emergency department. And both men and women reported an average 1 to 3 times to visit the emergency department in the last 6 months. Level of risk identified by the tool, the ISO tool and the TRS tool, was around 3 points, very high. Important percentage of loss of functionality in every of the items was also found. Cognitive status was affected. And as we expected, high prevalence of depression, hypertension, cardiovascular disease, and diabetes. The main reason of medical service request was abdominal pain and then neurological symptoms. But the truth is that there was an important variety of symptoms. And this is an issue because doctors always feel uncontrolled with all patients because they have a lot of unspecific symptoms and they cannot do a diagnosis. And an analysis of components reveals that more than 50% of the population is affected in every item, and the situation does not change, does not improve 2 months later at the visit at home. And I have to say that slowness was impossible to measure at the baseline because the clinical condition of the patients. And when we analyze the number of positive points and the number of components affected, more than 80% had 2 or more components affected. And on this slide, I present the frequency of witness in 4 different moments: baseline, discharge at the emergency department, discharge at hospitalization, and 3 months later. And the frequency between men and women of witness is really, really high, regardless the moment of evaluation. I mean, things do not change in the follow-up. The mean for women was around 5, and the mean for men was around 14 or 16, which is really low. And of course, as a consequence, almost all the sample is frail, and the situation also does not change at the visit at home. Of course, we measure grip strength according to the cut-off points and according to the criteria of Linda-Fried, adjusted by body mass index. And as a preliminary conclusion, we have to do much more analysis. Patients admitted to the emergency service are in critical condition, and delay in the process of care is a possible reason. Conditions of women are worst in terms of frailty, prevalence of chronic diseases, and some other social variables. Many are alone. No improvement of grip strength values was seen at the visit at home, and no association with some variables, but of course we have to do more analysis. And I think the value and cutoff points of the components of frailty have to be reconsidered in light of patients really seriously ill, and maybe it's not useful to measure frailty in this context. So in my point of view, it's important to understand frailty as a multidimensional concept. It is not clear how some variables have an additive or synergistic or multiplicative effect. It represents multiple organ system dysfunctions, but causality, it's not very clear. For me, it's not useful to see frailty as a binary system, to have or not to have frailty. And it's necessary to capture the full spectrum of the condition. Also, we have to study the effect of disadvantage at early life and the mechanisms of compensation also are important to study. And it is possible that research in the part of the clinical criteria cannot be extended to population level. And it's possible not to be applied this concept to patients at the hospital. And slowness and weakness should be standardized and validated in a very independent way. Weight loss, exhaustion, and low physical activity have a different application, epidemiological, and its potential for bias is very high. Long-term longitudinal studies are needed, and many different interventions that are running by now, trying to modify lifestyles, exercise, nutrition, educational programs for delaying the appearance of frailty are important, but we have to answer if frailty screening is really useful and to what extent. And just some remarks about causality. It's interesting to see that there are a lot of connections and pathways between concepts, and consequently, this causality is not very clear. For example, gait disturbance and low weight predict dementia, but cognitive impairment and depression also predict decreased strength and is related with frailty, and positive affect and the concept of locus of control are opposite to frailty. So I really want to end the talk with this paragraph, which I think that it's really true and it can be useful to think about the topic and to maintain the possibility of criticize our work and our main aims. So just to finish, I just want to put a nice picture of Mexico. This is another island, it's Holbox Island, that means black hole in Yucatan, Mexico, as beautiful as Galveston. Thank you very much for your attention. Thank you.
So we have time for some questions. So if questions for Dr. Yes.
Carmen, thank you very much. I was wondering if you could talk a little bit about long-term care. And you mentioned that there are no statistics, but is there any long-term care institutions? Is there evidence that there is meaningful or significant?
Yeah, well, recently, the National Institute of Geriatrics, that you know very well, performed a census of these institutions. The problem is that there are institutions for long-term care, but there are basically non-governmental institutions, and they do not have basically a public scheme. I mean, the state doesn't have the responsibility of providing this long-term care. It's a responsibility of the family. And they sometimes find some charity and some sort of long-term care, but in fact the regulation is really poor, and sometimes some nursing homes are in a very terrible condition. So this part, of course, has to find a solution for Mexico. You know.
Compared to the United States, France, Germany, the other developed countries, what percentage of the population falls in the aging quartile as opposed to in the other developing countries? I know you have a fertility rate of 2.2 as opposed to the United States 1.8.
Yes.
And that means in the United States within a few years there's going to be a whole lot more of us in the older category.
Yes.
How
Yes.
is this comparing in Mexico?
Yes, the fertility rate is similar to Brazil. Brazil has 2%, similar to Argentina. It's around 2.1, 2.2. And the percentage of aging is around 9% now. But the problem is the speed of the process. We just have few years to be prepared, and we are not prepared. That is one of the problems, no. And this figure will change in the following years in a very dramatic way. No.
Essentially, you showed that between 95 and 100% of people in your study were frail, and so the cut points perhaps are not correct for hospitalized patients. Do you feel like that's more of an issue with cut points, or do you think it's more of an issue with the, there's really not a consensus definition of frailty, so there's a whole bunch of different ways that people, even for mobility, sometimes people use self-reported through like a CATS type scale, sometimes we do walking speeds, so you're actually testing mobility.
Yes.
Do you feel like it's an issue with the fact that studies aren't done similarly, or do you think it's more of an issue with the fact that frailty perhaps is just something that all old people that are hospitalized have?
Yeah, well, in the case of the previous 9 reports, yes, of course, there are methodological issues because every paper, well, not every paper, but some of the papers measure in a very different way, and some of them just use the self-report. In the case of the emergency department, we try to apply the exact criteria and the exact process with the equipment and adjustment and everything. So I do not have the exact answer. Someone told me that maybe in the context of very seriously ill patients, frailty doesn't have sense. So because everybody is frail, so it's not possible to discriminate, and it's not useful for clinicians because everybody is in the same situation. I have to do more analysis and I have to complete the follow-up, but my preliminary conclusion is that frailty in this context and with the phenotype maybe it's not very useful, because in fact the level of impact and the level of disease of the patients is really, really high. I mean, the patients are in a very bad condition. Yeah.
So those were patients in emergency rooms.
Yeah.
I wanted to ask you something, a slightly different question. You were director of AG in a unit within the National Institute of Social Security in Mexico, which is a large institute that provides health care for about a third of the country, right? But it's a closed system, so you have a lot of information about the patients in there. Is there a potential to use that data, the data from the National IMSS, Social Security Institute, to study longitudinally the progression of frailty, for example?
Yes, I think it is possible. IMSS is quite different from the other institution. It's much more organized and it's more structured, and the population is basically depending on the level of employment, and we had electronic file, but the problem of the electronic file is that only works in the first level of care, in the family medicine level. But it's possible to have more data to integrate the concept of frailty in the population. That is possible. I don't know if the question is, it's possible. It's not easy, but yes, there is possible to have the information from the electronic file in the first level and to try to integrate some sort of frailty index. Maybe frailty phenotype is more difficult because I don't know if as a national system, slowness and weakness are measured by a routine in the system. But, well, we can check it and we can do something about it.
I think when you show the diagnosis, the percentage of it show that people wait and go to the emergency room if they are very sick. Because it is unusual that 50% of the people will have abdominal pain in that cohort. We know that people in Mexico, for example, go to pharmacies or local dispensaries or charities in neighborhoods or so to get prescription for other problems. So probably they don't get to the emergency room, but when they are very sick with conditions like severe pain or something, so this may bias into this population that reach the emergency room is very sick.
Yes, but the problem is that everybody reaches the emergency department very, very ill. And the problem is that the health system in general is not responding. I mean, people are going to the clinical room at the pharmacy next to the home because they want to find an easy solution and a quick solution. And the system, the social security system and the health system in general is, it's not responding. So yes, we have a problem in terms of how to face these needs. And also, there is a problem with the staff, which is not prepared to face these specific clinical needs of all the people in the emergency department. They don't know how to do and what to do with them.
Thank you very much.
UTMB Health, working together to work wonders.